learning live discussion with the guide group. And today our topic of discussion is ovarian cancer with this management, and afterwards we are going to do the multiple choice question. So what we are going to have it here, was glad to be admitted. So afterwards, what we are going to have it here, this ovarian cancer. Which first we have to do the summary. Summary, we according to that one, the summary will be that this is the, because I'm going to tell you the this all the ovarian cancer, which is important points which are important for the MCQ point of view. Okay, so this is the thing we have to understand, that the ovarian cancer has the highest mortality of all the gynae cancer, of all the malignancy, gynecological malignancy like endometrial, cervical, vulvar. In this, the top one is the ovarian cancer. Why it is the ovarian cancer is on the top one? Because it is diagnosed late, and it is diagnosed late means this will be mostly it is diagnosed in the stage 3, most of them. That's the one. So we'll do it, what's the percentage, but first we are giving the summary. So, and then afterwards he is telling that epithelial cancer is the most common, because there are different type of ovarian cancer. Among them is the epithelial is the most common one. Then he is considering that the inheritance will also come here. Previously they are saying about the cervical cancer there is no inheritance. Inheritance means genetic predisposition, but now new research also telling even in the cervical cancer there is a genetic predisposition is there. This is their diagnosis. So if we are now we are considering about the ovarian cancer. So the ovarian cancer, 5 to 10% they have a inherited predisposition. Okay, so this the second one point. And then how we are going to diagnose it? Diagnose is with the involvement. We will do the measurement of CA125 and ultrasound. This we call risk malignancy index, RMI. And the treatment will be the advanced epithelial cancer treatment is usually the debulking surgery and the chemotherapy. And the survival benefit he is talking about, if will be increased if this surgery has to be done in the oncology center. Okay, oncology center, gynecologist, oncologist, he will be, if he will perform the surgery. Okay, so that what he wants to say, that if we will consider other things, that what is the we already say there is two treatments. Mainly the treatment of this cancer is the debulking surgery and the chemotherapy. Sometimes there is a chemotherapy. Which agent we are going to use is the most common important agent which we are using, it is carboplatin, and alternatively paclitaxel. Okay, so these two agents are the chemotherapic agents. We have to understand one thing here. If the surgery is not possible, okay, then we have to use the chemotherapy. This is the best things I'm talking about. The we are talking about the summary. We will discuss this one by one, but we are talking about the summary. Okay, then he is talking about, okay, these are the things which we are doing it, but he is telling it these are not, these are the palliative symptoms, prolong the life, but really they are curative. Curative is means whatever the treatment we are giving it, only in the, if it is diagnosed in stage 1, it can prolong the survival rate, but mostly the all the treatment which we are giving, only they are rarely curative. Okay, so he said that that there is a new, because of this reason they are developing all the times a new development for that improvement of the outcome. So this new treatment is the ultra radical surgery, okay, and intraperitoneal chemotherapy and the novel drug treatments. So this is, I'm talking about the summary. So now if we will finish it after, yes, I'm going to, yes doctor, I'm going to put it afterwards, this thing in the YouTube. Okay, you can on the YouTube, and we are going to do the MCQs about this ovarian cancer. So now what we are going to do, the incidence, the lifetime risk of ovarian cancer. We say ovarian cancer means OC. In the developed world, we are not talking about the developing world. So because most of the research and everything is coming from there, so they talk about their countries. This is the developing countries, is risk is 1 to 2%, and the 75% diagnosed above the age of 55. So this is a very important MCQs. The risk is lifetime risk 1 to 2%, and 75% they are diagnosed above the age of 55. And the 5-year survival rate is affected by the stage. More than 90% is stage 1, or stage 1 they diagnose. Okay, if survival is the we are talking about the 5-year survival. If diagnosed in stage 1, it will be a 90%. Okay, but if it is if it is if we will go to the stage 4, it is the survival rate is only 10%. So if we'll consider all the stages, okay, so he is telling the most important MCQ. I make it a star here. This is the most important MCQ which they are asking. It approximately two-thirds of the cases are diagnosed in stage 3. That's the reason it is having the highest mortality rate. So I hope it is clear for you people. Okay, now the overall, if he will ask you the overall 5-year survival rate, it is only 42.9%. So sometimes we don't remember this 42, so we can say it 43%. Okay, if the MCQ can. So the thing is that prevention, see, we have to know, understand there is some screening methods which we are going to have it, which make it that prevention we can do it. And see, in the cervical cancer, the screening method is the only all the cancer, if we will consider, the best one is the cervical cancer, which is having a screening method. But if we will consider to other cancer, there is not a single reliable method which we make the screening. So what he is talking about the prevention, he is telling, if we will consider the breastfeeding, the OCP, and NSAID, non-steroidal anti-inflammatory drugs, they appear to protective. Please remember the question, MCQ question is will there, what are the protective factors and which are the factors which increase the risk of OC. So these are the protective factors. One is breastfeeding. Sorry. Second one is the oral contraceptive pills, and third is the NSAID. Okay, and the most important one is the aspirin. These are the protective method. Then if we will go to the mostly the high risk, which is the factor, the he say endometriosis having the highest risk of ovarian cancer. So please, we have to understand that thing. And there is other drugs which we call it the ovarian stimulation drugs. We have to understand there is a, when we are giving the fertility treatment, we are making the ovarian stimulation. Okay, the any drugs. So he is talking about, if we will give the ovarian stimulation drug, it will there is an increased risk of the borderline tumors. Okay, we have the borderline tumors, the malignant tumors, and the benign tumors. So the borderline tumors increased risk is the ovarian stimulation drugs which we are using for the fertility. And the family history of the ovarian or the breast cancer, this is the strongest predictor of the BRCA genes mutations. So endometrial, colon, ovarian, and other cancer, they are called the cluster of the familial cancer, which they make one word, which called the Lynch syndrome, or other name they are previously they call it HNPCC. Watch it, HNPCC, hereditary non-polyposis colorectal cancer. So they given this one Lynch syndrome or HNPC. Please, this is very important MCQ. Try to remember that one. And the family history. suggested high risk of development of the ovarian cancer. In their family, they have somebody ovarian cancer, so they have a high risk of the ovarian cancer. This is called the genetic predisposition. And this what he is talking about, the BRCA 1 and the 2 is also important in the lifetime risk. They have a lifetime risk of developing ovarian cancer. So if you will consider the BRCA2 carrier, if she is having a BRCA2 carrier, she is having a 27% risk of developing ovarian cancer. But if she is having a BRCA1 carrier, so she is having a between 28 to 44% risk of developing ovarian cancer. So it means here, if we will consider BRCA2 is the important point. This mutation, BRCA mutation, okay, 1. It will be 28 to 44%, and if we will consider BRCA2, we can remember it will be the half one, 27%. Okay, ji. And the risk reducing surgery is the most important, which they are doing it. Risk reducing surgery, what they are going to do it? Bilateral oophorectomy and hysterectomy. He is telling about BSO alone, along or with hysterectomy, is recommended in BRCA 1 and 2. Means this is and Lynch syndrome carrier respectively. What is this meaning? This meaning is that any woman who is carrying the gene, BRCA gene 1 or a 2, so she has to, after completing her family after 35, mostly they are doing it after 35. So age 35, completion of the family, and if she is having a BRCA1 and BRCA2 gene, age more than 35, she can do the risk reducing surgery. What is risk reducing surgery will be? It will be BSO and hysterectomy. Sometimes they will do the BSO and sometimes they will do the hysterectomy, but better to be both hysterectomy and the BSO. Okay, so what he is telling it, BSO is most important in the if she is having a ovarian and the breast cancer. If some women have a this thing, so but he is telling it still there is a small primary peritoneal cancer risk is present. So that's the reason they want to do the hysterectomy also. This is the main basic is there. Okay, so we done that thing. Other things, now we will do the screening. There is no current evidence for the screening of ovarian cancer that will fail to decrease the mortality. Please we remember we have to this one, okay. And because why they say it will increase the risk of the surgery, because we have only one method of this one for the diagnose, if risk malignancy index. So if we have this risk malignant index, what how we are going to calculate this? There is a one MCQ will come. Is coming very important MCQ, how you will calculate the risk malignancy index. So this will do it down a stair, just I'm telling it. Okay, so what is the family history criteria? Means two individual with ovarian cancer who are the first degree relative, or one individual she is having a ovarian cancer, or she is having a breast cancer, less than 50 years of age or less than 60 years of age, and she is a known case of the BRCA carrier. So this one we will consider as the familial history. So now what he is talking about the screening. Screening we already talk about, there is no specific values of the screening for the ovarian cancer like risk malignancy index. What he is talking about, CA 125 is the basic. When we will do it, we will do the screening with pelvic ultrasound and the CA 125, isn't it? So he is talking about what is CA 125. Sometimes this MCQ will be there. What is CA? CA means carbohydrate antigen 125. Okay, CA means carbohydrate antigen. C means carbohydrate, A means antigen 125. Okay, ji. With is a glycoprotein, CA125, we will consider it is a glycoprotein that is released in the blood stream by any condition. This will disturb the peritoneum. Which are this one? It can be a peritoneal cancer, cirrhosis, is cardiac failure, okay, congestive cardiac failure, endometriosis, PID. and pregnancy. So my friends, this is one of the very important MCQs that in which CA125 is also increased along with ovarian cancer. So this is the points we have to know. These are the things which CA125 is increased. But he said low value, even sometimes there is a low values is coming. So it is not a specific in low levels, even she is having a high risk of ovarian cancer. So sometimes this value will come low. So please, we have to depend mostly about these values. Okay, ji. So he is telling, if we find any woman having a pelvic mass, and her age is more than 40, so we have to do the risk malignancy index. This is very important one. So how we will do the risk malignancy index? This is the one, it is here, risk malignancy index. How we will do it? RMI is equal to U into M into CA125. So what is this? U means ultrasound, M means state of the woman, menopausal state. Means she can be pre-menopause, menopausal, or she can be post-menopausal. Okay, so if this is the thing, so what we are going to do? If we will calculate the ultrasound score 1 for any one of this one we will give 1. Multiocular cyst, solid area, bilateral lesion, ascites, metastasis. So every point we have here 1, 2, 3, 4, 5 points. We have a 5 points, so we'll give her the in 5 points, one will we get it. If we get multiocular cyst, we will give 1 point. Okay, we finish that one. Then if we say ultrasound score 2, or if 2 to 5, we will go give the score 3. We will give the 3. Okay, marks will be 2. Score we will give 2 score if any of the 2 or 3. Means if we have solid area will be there, ascites will be there, so we'll give marks 2. So what we have, ultrasound score will be 0 if and none of the other anything we find it. And if she is perimenopausal, score 1, and if she is menopausal, we will give the score 3. So how we are going to calculate ultrasound? U means ultrasound. If we have 2, so we'll give her 3. Menopausal state, whatever it is, menopausal means she is postmenopausal mostly, because this is common in postmenopausal now. So we'll give 3. If it is perimenopausal, okay, we have to give 1. And CA125, whatever the value of CA125 they given in the exam, they will give in the exam the CA125 value. So if this CA125 value will be there, we will do with this formula, we will calculate, and according to the calculation, sometime they will give you the calculation. Okay, so you have to remember that formula, and they sometimes they will give you the calculated value. Okay, so if they give you the calculated value, they will give A, B, C, D, or all of the above, whatever they will give it. So we have to understand, we will calculate ourselves, and then we will get that whatever the value they have given to us. So okay, we finish this then. This now the other question is that type of the ovarian cancer. What are the type of the ovarian cancer we have? Classification of the ovarian cancer means epithelial cancer, sex cord cancer, and the germ cell tumors. Germ cell tumor, this germinoma is the most important one, then the yolk cell. Okay, and the sac cord tumors, the names are there: granulosa cell, thecoma, fibroma, Sartori cell tumors. Okay, and the surface epithelium, what type of they have? The serous, endometrioid, clear cell, mucinous, and transitional cell. So my friends, so this is the this is okay. I will try to put this thing in the group, this classification, this one how to do, and this one is also I will put in the exam in the group. Okay, so type we already know. One thing we have to understand, one by one we will do it. Means epithelial tumor, how much common? They are 70% common. Okay ji. And mostly the high grade high grade, mostly they are high grade. 70% if they are high grade, only 5% are the low grade serous cancer, we find it out there. Then he is telling the high grade serous are strongly associated with BRCA1 and 2 mutation. Okay, serous one is the one who is attended. Then he is talking about, if we'll consider the mucinous ovarian tumors, they are commonly found, but it becoming increasing evident most of them are the metastatic. Most mucinous tumors, if we find, most of them they are the metastatic tumors. This is the things we have to do. We don't need more than that one, because not more than detail for the theory point of view. Here we have to understand the sex cord stromal tumor. Sex cord tumors, they are 7% of all the malignant ovarian tumors. Means 70%, 100% they are malignant ovarian tumors. So in them 7% are the sex cord. Okay ji, sex cord tumors. And what does this mean? Sex cord means they are hormone producing. Please remember that one. Sex cord means hormone producing tumors. So what is the hormone producing tumors? Are the one these one they are producing the hormones, and which is the most important hormone they are producing? Estrogen. Okay, because they will produce the estrogen. After estrogen they will get to the hyperplasia, and hyperplasia will lead to the cancer. This is the whole theory which they are talking about. And sometimes this mostly this one lead to the endometrial hyperplasia, and this one they are mostly they are common in the sixth decades, present in the sixth decades, and less common in young and the prepubertal women. So please remember that these things, they are less common in the younger women, but most common in the after the 60 years of age, means older age women. Okay ji, so the same thing, fertility is sparing the late, because late recurrence will be also there, so they can have a fertility sparing surgery can be done if they diagnose in the perimenopausal woman. Okay, so malignant germ cells, if they were found with malignant germ cell, means dysgerminoma, which I am telling you. Dysgerminoma mostly occur in adolescent and adulthood, means young girls. Okay, and they are mostly bilateral up to 20%. And here we have to understand the sex cord tumors. They are unilateral. Please remember, they are unilateral, but the dysgerminomas are the bilateral. Please remember, these are bilateral, and they will highly produce LDH. So this sex cord, they will produce estrogen mostly. Okay, and the LDH one, they are produce sex germ cell tumors, they will produce LDH. There is a one chart, a different type of the tumors what they produce it. So I already put before one that chart, but I will try to find it, that one, and I will put it again in the group. Okay, so we finish that thing, finish the things, we finish it. The most important thing that they are highly radio sensitive. So highly radio sensitive means the platinum based chemotherapy is preferable. Okay, so we done how we diagnose it. Mostly we diagnose that ovarian cancer with this one I told you na, CA125, if she is symptomatic or asymptomatic. Mostly how they will present, they will present with persistent abdominal bloating, early satiety, urinary frequency and urgency, and change in the bowel habit, and she will have a pelvic and abdominal pain. So this is the presentation of the patient. Then we have to do early stage cancer, mostly they are asymptomatic. I told you already that they are diagnosed late stage 3. So what we will do, we will do the risk malignancy index. This we already know it. Okay, we done that one. Then we will do the staging. The staging is staging here, please. This is the staging. Okay, this is the latest staging, 2013. Mostly there's the stage 1 they divided into up to C, stage 2 they divided into A and B, and stage 3 they divided up to C, and stage 4 they divided into stage 1 and 2. So please, we have to remember about how we are going to remember the stages of the ovarian cancer. This is the biggest dilemma, and this is very horrible problem for how we will remember this staging. It is a very hectic one. So we have to just remember the black one. for my point of view. How we will remember the tumor? Stage 1, the tumor is confined in the ovaries and the fallopian tube. It is not going away from the ovaries. Okay. A means one ovary is involved. B means both ovaries are involved, the tumor. Okay. And the C is going to be divided into three. Stage means C1 means surgical spell during the surgery, and she capsule is ruptured. C2 means capsule is ruptured, and C3 means there is a malignant ascites or the washing in the peritoneal fluid. So these are the stage 1 and 2 means tumor or one involving one or both of the ovaries of the and the peritoneal means and it will come below the pelvic brain. Means what? Pelvic brain, it is coming, it is going to the pelvic tissues. Pelvic tissue means extension to other pelvic tissue. This is what he wants to say. It is going implant to the uterus and to the fallopian tube. Means it is now from the ovary, it is coming to the uterus. So the uterus will be involved now in stage 2. And stage 3 means it is involving one or both ovaries, the tubes, the uterus, and it is also involving the lymph node. Okay, involving the lymph node. Stage 3 will stop 100%. It is involving the lymph nodes, pelvic and the para-aortic lymph node. So it is going to be very big, this problem. So we are not going to remember all these things, just this one we have to remember. And stage 4, it will involve the means involve the bladder and the rectum. So this is the one, and with the lymph node. Okay, this is our the way which I done my classification. I'm doing like this. Okay, so investigation we already talk about, now we are going to talk about the treatment. If it is diagnosed in the, here we have to remember one thing here. The treatment, if she is in the reproductive age group, then the treatment will be little different. She want the reproduction, she want the fertility preservation, so we'll do the treatment according to that type of the thing. But main treatment is the treatment of this epithelial ovarian cancer is the surgery and the chemotherapy. So what we are going to do, if we are going to do the surgery for stage 1, we have to do the total abdominal hysterectomy and BSO. Okay ji, this is the primary. This is we call the ovarian cancer is treated primary surgery debulking laparotomy, which we call it debulking laparotomy. What does this mean? Debulking laparotomy means we are not going to let any spot of the cancer remain there, but sometimes it can be we cannot remove all the things, so not left less than 2 centimeter. So this is the most important point of the MCQ. Okay, so we'll do the debulking surgery, and after that we have to do the 6 cycle. Please remember this 6 cycle of platinum based chemotherapy. These are the 6 cycle we will do. Okay, already we told that cisplatinum, and then alternative is carbopactacil. So this is the thing which we didn't pactacil, sorry. So this thing we have to do. This is for the stage overall we are talking the treatment. Then if we have the advanced stage cancer means stage 3, here we have to do the debulking surgery. If it is not possible, then what we have to do, the interval debulking surgery. What is the meaning of interval debulking surgery? In stage 3 and stage 4, what we are going to do? We do first the chemotherapy, okay? Then we will do the surgery, and then after finishing the surgery, we will do again the chemotherapy. This is called the interval debulking surgery in stage 3 and stage 4. Okay, because sometimes there is most of the time surgery is not possible. Okay, so here also he is talking, if we will go to the stage 2 to 4, he is talking midline laparotomy, which we called already now, midline laparotomy, which we call a debulking laparotomy. This he is talking about what we are going to do. This is a very important MCQ question. This will involve the midline laparotomy, sampling of the site. What we do in that one? Please remember the sequence, because sometimes they will change the sequence, and this is a very important question. So what we will do, laparotomy, we will do it the ascitic fluid. First we will do the sample of ascitic fluid or the peritoneal washing. For the cytology we will take sample of the suspicious pelvic and para-aortic lymph nodes. We will take it infra cholecystectomy, and then we can do the total abdominal hysterectomy and BSO with removal of intact of the encapsulated mass. Okay, so this we call it debulking surgery, debulking laparotomy. So these are the points. Please remember one by one. So this the sequence. They can change it. Okay, I will put it in that one. This topic there, so you can have it there from there, this this topic also from there, and it will be very easy if you will have this. My marking also will be there. So what we have to tell it, so debulking surgery will be what laparotomy surgery will do. Midline laparotomy, this we call it midline laparotomy. We will do the sampling of the ascitic fluid or the peritoneal washing of the cytology, sample of the suspicious area, pelvic and para-aortic lymph nodes, and infracolic amentectomy, total abdominal hysterectomy, bilateral salpingo-oophorectomy, and we have to remove the capsule intact. So these are the things which there is a very important MCQ. They will give it in sequence. Please remember in the sequence, because they can change it. They can say, okay, sampling of the suspicious pelvic and para-aortic lymph node, they will cut, and they will give this option as a B. And in option A, they will give all the things. So we will choose option A if it all the things say. B, maybe they will not put the option this para-aortic lymph nodes. So, and C, they will not put the total abdominal hysterectomy. So they will ask what will be the option of the midline laparotomy which we are doing. So these are the ones we have to remember by sequence. Okay. And this we call it the cytoreductive surgery, optimal cytoreductive. 80% we will do it. Okay, so these are the things which we finish it here. And chemotherapy we already talked. If we cannot do the operation, it is not possible to go for the surgery or anything, then we have to do for the palliative carrier. Palliative carrier means we have to care the patient with only the symptomatic treatment. Symptomatic, okay, means symptom, whatever the symptom, because she is having a distressing symptoms like nausea. Distressing symptoms means like nausea, pain, loss of appetite, constipation, abdominal distension. These are the one. So these we have to do by the according to that palliation which we have it. Okay, the psychological treatment we have to give, this is very important here. And okay, we finish this our topic.